the corticotomy showed a more significant increase in the rate of tooth movement, and which means that, and they put this in between brackets, 2 to 4 times faster. And they said the position made the tooth movement faster by twice faster. Okay. So we know that systematic review is a very good evidence, but sometimes you are misled by the authors, and this is not the reality. Okay. If you look here, so this will come to this question, which is very important question. Can you trust author's conclusion? So what if you can't trust the author conclusion? What you will do? Now, after this story, I started doing some, I will present this in Nemri et al. Article, which was published 2013. This was a review for the procedures that can accelerate orthodontic tooth movement. He categorized these things in 3 categories: biological approach, non-surgical adjuncts, and surgical adjuncts. For the biological approach, he reported the prostaglandin E, cytokines, RANKL, MCSF, vitamin D3, parathormone hormone, relaxin. And now, this was not published in that study. Now, recently, in 2022, mostly, the platelet-rich fibrin and platelet-rich plasma were introduced to accelerate orthodontic tooth movement. The non-surgical procedures included vibration, low-level laser, photomodulation, and other techniques. The surgical adjuncts or surgical procedures included interseptal alveolar surgery, corticotomy, then position techniques, and most recently, cortication and decision, and most recently, micro-osseo perforation. I think this is the most interesting techniques that the orthodontists, or which are used in orthodontics for acceleration of orthodontic tooth movement. For the surgical adjunctive procedures, the first was corticotomy, and this corticotomy was introduced to orthodontics by Cole, 1959. And in this technique, they make perforation using bar to this cortical bone for all the teeth to accelerate the orthodontic tooth movement. Then in 2000, and something like this was in 2001, two case reports were reported by William Wilco and his brother Thomas Wilco. And they used this technique for the decrowding of these cases. After that, by 6 years, mostly in 2007, Versatility introduced the position. They used the piezoelectric device. After raising a flap, they used these cuts using the piezoelectric device, not the bar. They didn't use the bar. After that, by 2 years, also Dibert introduced the flapless position. And by this technique, they don't raise a flap, just they do this cuts in the soft tissue, then they do the cuts using the piezoelectric device. Most recently, as I said, the micro-osteoperforation was introduced by Al-Thani 2000. By Ali-Thani 2013. This technique depends on using micro screws, mini screws, propel, any device to make some holes in the bone and the soft tissue, and mainly in the bone with different might be depth, something like 3 millimeters, 5 millimeters, sometimes more, sometimes less. It's up to the authors. So what evidence say about the surgical adjuncts? We have done this study 2018 about position to see what is the effectiveness of the position in accelerating orthodontic tooth movement. And in this study, we did the meta-analysis and we found that the canine retraction rate, the main difference in the canine retraction rate in the first and second month after position were something like 0.66 millimeter in the first month and 0.48, almost half millimeter per month for the position in the first and second month. And this was statistically significant. If you look here at the meta-analysis, this is the meta-analysis of this study. And if you see some studies have a very wide confidence interval, which means that there is uncertainty in these studies. If you look here also in this study, which was not significant, you will see that the confidence interval was very wide, the range of the confidence interval. Mostly there was some heterogeneity, homogeneity between the studies, but the most interesting that the effect was the main difference was 0.5, almost 0.5 millimeter per month for the first few months after the surgical adjunct. For the treatment duration, we have found that this was something like 100 days from two studies included in this systematic review. Only 100 days, almost out of 365 or something like 1 year. Or for 12 months, we found that the treatment duration reduction was something like 100 days. And this was statistically significant. But if you look about these trials, which was included in those studies, if you see high risk, some concerns, most of these studies were from high risk of bias or at high risk of bias or at some concerns. So you couldn't trust these findings very well because you will see that the grading or the certainty in the evidence was low or sometimes very low. We have done another study about, it was overview of systematic reviews. In this overview of systematic reviews, what we found that all of these techniques were used in surgical adjunctive procedures. I mean by all is the three main techniques, like the decortications, micro-osseoperforation, and position. The canine retraction rate increased by something like 0.65 millimeter per month. For the first few months, always they do that for the first few months, first month, second month, and third month mostly. And rarely you will find a study have done something for the fourth month or fifth month, because at all cases you will find the canine was retracted to its position and there is no space and there is no need for another month for this study. Yes, in these techniques, if you see, we have done this position subgroup analysis, and in the subgroup analysis, if you see the position effect was less than the corticotomy effect, and the micro-osseoperforation also was less than the both. The effect of micro-osseoperforation was less than the both. But if you see here, you'll find that, yes, if you see there's overlap between the confidence interval of these studies, which mean that there is more consistent in the result of the position, while for the micro-osseoperforation, you will find some studies with a high effect and some studies with a very low effect or non-significant effect. So there is here inconsistency between the results of these studies. But if you will see the corticotomy also, you will find that there is heterogeneity between these studies and there is no overlap, which means that there is statistical heterogeneity and other issues in these studies. Then in the last year, we have done this study, which was published in the European Journal of Orthodontics about the effectiveness of platelet concentrates which mean concentration include both types of platelet-rich plasma and platelet-rich fibrin. And we found that the platelet-rich injection of these PRCs increase the canine retraction rate by mostly 0.28 millimeter per month. And the confidence interval was wide to some extent that raised some uncertainty in these findings, although the p-value was less than 1 per thousand. And this was, as I told you, in the first 4 months. If you look at the evidence here, you will see also there was a high risk of bias. You see the red means high risk of bias. Some concerns, if you look at the study, this is the study ID. And if you see here, there's some studies with some concerns, with some studies at high risk of bias that also reduce the quality of the evidence. Here also, if you look at this forced plot, you will see for the first month, second month subgroup of first month, second month, third month, and the fourth month. And if you will see, mostly the first month, there was more acceleration than the second month or the third and fourth month. So now, also the certainty in the evidence was low to very low in some outcomes like the molar anchorage loss. The evidence was very low, while for the canine retraction rate, it was low while including 6 RCTs in this outcome. All of these studies considered some of patient-reported outcomes like pain, how much pain he will get after this procedure, the apprehension, or some other issues that it was related to these procedures. But frankly, no one comprehensively assessed that how much the patient will pay for these procedures or how they will accept this procedure. This was published lately in the American Journal of Orthodontics about patient, parents, and orthodontists' perceptions of the need and the cost of additional procedures to reduce treatment time. And in this study, 70 of orthodontists replied to the survey were interested in adopting additional clinical procedures to reduce treatment time. So why all of this? And I think this is natural outcome because if in orthodontics, the orthodontics process take a lot of time. Like mostly it's more than 12 months. Sometimes it's 24 months, and sometimes it's up to 36 months or 40 months. So you see that the patients always bone the brackets, and in the first appointment, he will be very happy. The second appointment, he will be happy. But after that, this will be boring for him, and he will start asking, when we will finish this study, when we will finish the orthodontic course, when we will debone these brackets and blah, blah, blah. So this is important outcome. The treatment duration is important outcome for the patients. Also, this is important outcome for the orthodontics. Why? Because also the orthodontists have appointments, have busy clinics. They don't need a lot of patients every day. It's exhausting. So they should finish the patients quickly and start accepting other patients in their practices. So this outcome is very interesting, the treatment duration for both the orthodontist and the patient. And from these results, what the authors found, they found that the invasiveness of the procedures was inversely related to its acceptance in all groups surveyed. So what does this mean? This means that if the surgical is very, very, very invasive, okay, that means the patients would be less accepted or they will accept this, they will not accept these procedures. While like micro-osseoperforation, the patient, okay, they will be well accepted for this procedure, or they will accept this well, while the other procedures like the corticotomy, raising a flap, and do all of these cuts to the bone,
ما خلص
they will
ماكو.
not accept, they will not accept this easily. Please close your mic. Okay. For the patients, also, they were willing to pay extra money, extra fees, up to 20% just for this procedures if the procedure will reduce the treatment time. So they will pay money, okay, up to 20% if this procedure will accelerate the orthodontic treatment and will reduce the treatment time. Now, till now, no one was interested in the minimal important difference, the clinically minimal important difference, or the smallest worthwhile effect. And we were lucky to do a study with Gordon Guyat in the last year about this, and now it's under review in the European Journal. So what is the minimal clinically important difference? The minimal clinically important difference is the smallest difference that the patient, not the clinician, the patient perceives as important. So how? I will give you this example. If we set the patient to the patient, we will extract a tooth, okay, and we will give you this anesthesia. So how much pain in degrees, like out of 10, from 0 to 10 on this scale, visual analog scale, how much degree you will be interested that it will be important for you that the pain is increased or the pain is decreased? So sometimes he will say that 0.5 half degree out of 10 is important for the patient. Might be it's not important for us, but sometimes it's important for the patient. And what do you think this half degree? Half degree is almost about the penetration of the soft tissue. So the penetration of the soft tissue is very important for the patient, but it might be not important for us. So sometimes you should use this spray, anesthesia spray, might be to diminish this feeling of the needle penetration. On the other hand, there is another question in this study which we have done, and it was a very, very important study. What is the smallest worthwhile effect? I will see this in Arabic. So the difference, the minimal important difference, that mean that الفرق الأصغري المهم. So الفرق الأصغري المهم هو أصغر فرق ممكن أن يقول المريض عنه أنه مهم، بينما التأثير الجدير بالاهتمام، أصغر تأثير جدير بالاهتمام هو فعليا أصغر تغير يقاس، بينما نعطي المريض بعض الفوائد للتكنيك بعض السلبيات للتكنيك. So the smallest worthwhile effect، التأثير الجدير، أصغر تأثير أو التأثير الجدير بالاهتمام الأصغري، is the important change measured with the benefit harm trade-off method. So what's the benefit harm trade-off method? If we ask the patient, what is the minimal important difference in the treatment duration of orthodontics? And the patient said 1 month. 1 month is very important for me as a patient for reduction. So if we said to the patient, okay, we'll give you this needle or for anesthesia, and we will raise the flap and we will cut the bone, and this will take half an hour, and after that you will have a pain for the first 2 days or 3 days. You can take analgesics, and you can take medication to relieve the pain, and this will increase the treatment duration. So what is the treatment duration reduction that you feel it's worthy to undergo this procedure. In this study, I will show you the finding of this study. The minimal important difference in our study was 1 month for both treatment duration, 12 and 24 months. So in other words, if the treatment duration that the patient knows that our treatment duration from the start, you will say that, okay, you need 1 year, you need 2 years, okay? So the patient for both durations, he said that 1 month is the minimal important difference. On the other hand, we asked the same questions again, and we said that the smallest worthwhile effect. We said to the patient, so what do you think if we will do this anesthesia and we will do this flap raising, or without flap raising, we will do cut to the bone, and this will be, there will be some bleeding, and after this, you will have edema and you will have pain, and you will pay extra fees, something like 10%, 20%, it's up to the surgeon. So what do you think? The patient said, okay, so I need at least, he said, at least, not, not I need 4 months. He said at least, which means 4 months, 5 months, 6 months, something like that, for the 12 months. And for the 6 months, for the 24 months, he said, I need 6 months. And I will, again, I will back to the first slide when I shared the story of one of my patients. When I said to him, some studies said that, okay, this is, this will the acceleration of the tooth movement would be something like 2 folds, 2 times or 3 times or 4 times. He said 2 times. That's mean you said to me, I need 2 years, so now I need 1 year. Can you guarantee this 1 year? If you guarantee this 1 year, I will go and undergo this surgery or surgical procedure. I said, no, frankly, I couldn't give you a warranty that this procedure will reduce the treatment duration to 1 year. So now we should focus on these outcomes, which is very important to the patient. It's not about us. It's not about fathership to the patient. It's evidence-based practice. In the evidence-based practice, you should ask the patient, you should share the patient the decision, and you should do that based on the evidence. Like, okay, it's not about solid evidence. There is evidence say that, and there is other evidence say that. Yes, the evidence say that, okay? So the treatment duration reduction is 100. If you see in this study, it was 100 from out of 1 year, almost 1 year, 393 or 324, almost 1 year. So this was 100 days. So is it important for the patient to undergo this surgical procedure, pay extra money, and do whatever he should do, and take this risk of pain, bleeding, risk of infection, and risk of all of these things, and paying extra money for 100 days? Might be this is not worthy for the patient. It might be worthy for us, or it might be worthy to experience something new in orthodontics. But frankly, this is not important or not worthy for the patient. As I told you in the first of this lecture, that my patient said to me, if you give me a warranty that you will reduce my treatment by 1 year, so I will go to this procedure. Again, I will say something very interesting, that you couldn't accept the author's conclusion. So the author's conclusion in this study that I shared, 2018, which was published in Korean Journal, what they said it's the corticotomy accelerate the tooth movement by something like 2 to 4 folds, or 2 to 4 times, and precision twice, increase the orthodontic tooth movement. We should compare the outcome that the authors measure to the outcome of interest of the patient. So if the outcome in those study was canine retraction rate, we should ask the patient if the canine retraction rate is very important outcome for him. It might be not important outcome. The important outcome for the patient is the whole treatment time, the whole treatment duration. It's not about accelerating only the movement of the canine. It's not about accelerating only the decrowding a procedure like, okay, this will take 4 months, so I will do this decortication and I will make your teeth align in 3 months. So 1 month is not very important for the patient as smallest worthwhile effect. Okay, so we should compare the outcome in the study with the outcome of interest of the patient. Now, frankly, I'm not against these procedures in accelerating orthodontic tooth movement, but what is the question? The question, how can I utilize these in my daily orthodontics? How can I utilize these? Frankly, I will not adopt that making these surgical adjunctive procedures the patient to accelerate the canine retraction rate by 0.5 millimeter per month for 4 months, which is 1 or 2 millimeter. Then I will track the incisors, and this will take from me extra 6 months. I will give the details in 6 months. So this will reduce the treatment duration by 1 or 2 months. It's not important for me from the view of the patient. Okay. So I'm not against these acceleration procedures. There's very good acceleration procedures, but how wisely I use them? How can I wisely use these procedures? It's about wisdom. It's not about the procedure. So for me, I will present 3 cases. In those 3 cases, I used the surgical adjunctive procedures, and this was very, very important for me. And these procedures, frankly, helped me a lot in my practice, just only for specific cases. So if you look, the first one is moving the ankylosed teeth. So if you have ankylosis, you can use these procedures, and this may help you, but you should use according to the evidence. And how can you utilize these in the practice? This case was pre-prepared and also co-treated with Dr. Ayajuri and Dr. Yasser Rifai from Aleppo. And they obtained the first position in the posters in the last year in the orthodontic conference, I think, or surgical conference. Frankly, I couldn't remember very well. So in this case, this was 14-year-old old male, and his chief complaint was severely, his teeth were misaligned, and he is willing to align his teeth. The patient got the trauma when he was a child, and his mother, what she did, his mother re-implanted the tooth in its position, and after that, there was no growth in the, there was no growth in the alveolar bone, and the tooth was ankylosed. I'm not willing to go on these details. The facial symmetry and the midline. The midline was off, and you see the facial symmetry. The face was symmetric. There was some gingival display. If you look at the intraoral photos, you will see that there was severe crowding in the anterior area, severe crowding also in the interior area, in both lower arch and upper arch. The classification, the molar relationship was class 2, if you see here, and almost also class 2 1/4 on the left side, cross bites, multiple problems, and this ankylosed teeth with higher position, and the gingival margins was not consistent. If you see that, the photographs, if you see, there was a mild class 2 and be something like 5 degrees. You can see also the models. The crowding was something like the severe crowding was 10 millimeters in the upper arch and 6.5 millimeter in the lower arch. These were the objective of the treatment. You know that for the objective of the treatment, you need always to be optimal and to achieve the leveling alignment of the tooth, resolve these crowdings, obtain class 1, might be molar relationship and canine relationships, but sometimes you couldn't because you will end up with therapeutic class 2 molar relationship. You should also improve, in this case, improve the gingival margins, the anterior gingival margins, and finish your case and do this retention. But frankly, the ankylosed teeth was a problem in this case. So there was different scenarios. In the first scenario, uh, it was the extraction of the closed teeth and the 4 premolars. I don't prefer this scenario at all because in this scenario, you should replace the incisor with implant, and replacing this at this age is not possible. And you couldn't do that Maryland bridge for a long time. So frankly, for me, this is not a logical option. It's not a sensible option. The other option is the surgical luxation of the tooth, followed by orthodontic treatment. Frankly, this is a good option, but sometimes if you do the extraction, is not a good option. So for me, I can do this luxation, surgical luxation. Then I can wait with this premolar until this tooth will move. Then I can extract the premolar. But from the start, this is not, as I said, it's not possible because something can happen and you lose all of these things, all of these teeth, the 5 teeth, the 5 teeth. Other option is extracting the ankylosed teeth and the other premolars. For me, this is the optimal plan for this case because you will do, frankly, from this, this advantages of this technique is the reshaping of these tooth. Might be you will use this group function on this side. You will not use canine function. Okay, reshaping prosthetic soft tissue surgery to correct the margins of the anterior teeth. All of these are sometimes, yes, it's disadvantages, but we should accept these advantages. Why? Because this treatment is, the prediction is very high in this treatment. So I will not try with ankylosed teeth, and after 6 or 4 months, I will say to the parents and the patient that I should extract this tooth, and we will lose all of the 4 teeth, 4 premolars, and this incisor. So this is the most predictable treatment plan. And if this is my case, I will use this plan, not the other plans. But also the parents refused to extract this tooth, and they asked a specialist orthodontist to try to erupt this tooth. So he suggested that he can do this segmental osteotomy, which is a surgery, and in this surgery they will remove this tooth with a bone block, and they will move this bone block with the tooth to the new position. But this is a surgical procedure, and in the surgical procedures also you need a bone graft. This segment should be stabilized using something like splint, but in orthodontic you can splint this using the wire. Frankly, I'm not. I don't know a lot of this about this technique, but in this technique, you should, as I said, you should fix the block, and sometimes there is not sufficient periodontal tissue around this enclosed teeth to allow to do this procedure. You need sufficient periodontal tissue, sufficient bone to do this procedure. Lastly, we have this technique. It's called osteogenic distraction. In the osteogenic distraction, you will make also a block around the tooth, a bone block. And in this bone block, you will use a distractor. You know the distractor, which is something similar to the screw. And in this screw, you will do this 1 millimeter per day from this movement. And after that, you will remove this distractor. The disadvantages of this technique is that the distractor is bulky, sometimes it's inconvenient, and sometimes you couldn't use it in some might be in some areas that there is no space and you couldn't use it, like the anterior area is very difficult to use this technique or to use this distractor. So what I suggested to do something called osteogenic distraction with simplified orthodontic biomechanics, or I suggested to make the cuts using the piezo sessions, okay? Make this block mobile, the block of the tooth, and rather than using this distractor, to make some mechanics using orthodontic force to force erupt this tooth with the block. So what we have done, we prepared the case, extracted the premolars, and after the extraction, we made this alignment. After the alignment, we open the space, and opening the space here, there is a red notice that opening the space is not only for the tooth, it's not only for the crown, it's also for the root. We should open a space, enough space for the root, and at least 2 millimeters around the root from each side to do the cuts. After this, we got the CBCT, and in this CBCT, you can see there's a lack of this space, a lack of the lamina dura and the space around the root, okay? And you can measure the thickness of this cortical thickness. You can measure the thickness from here to here, from the palate to the buccal or to the labial bone. You can see that the thickness. To plan your surgical procedure, you need a very precise plan, because you couldn't cut or raise a flap from the palate. You should keep the blood circulation from the palate. So we planned for also you need the tooth length, because you should make these cuts up to the tooth or above the apex by 2 millimeters. And as I said, between the tooth, you should have these measurements. You should be very precise to plan to this surgery. And the surgeon was very expert, and you can see this neat work. He raised the flap, and you should keep this attached gingiva for 2 reasons. One reason is the circulation. The other reason is to not do recession, or to not might be to prevent the possibility of recession, of gingival recession. So you should keep the attached gingiva and make the cut 5 or 6 millimeters above this attached gingiva. Using the piezo or piezoelectric device, you should do these cuts. Good cooling, use water or normal saline, use normal saline. Good cooling to not burn the bone, because this is a major problem. If you burn the bone, you should make these cuts. As we said previously, you couldn't make these cuts from the palate. You should keep the palate as it, to keep the circulation, the blood circulation. Otherwise, لا سمح الله, this block will be necrosis or will be necrotic. After making this, you can use a sessile, okay, the surgical sessile. You can make this movement and see if this, all of this block should be mobile, okay? All of the block should be mobile, and you should move the teeth by your finger, and you should see that all the teeth, the tooth, and the block, the bone block is mobile. Okay, after that, suture. Nice suture. Then we started using, after a latency of 5 to 7 days, we can use elastics, okay, intraoral elastics to erupt this tooth, okay, to make this movement extrusion or eruption for the whole tooth and bone block. It's not about bone block. Now you can see the bone, you can see the tooth level, you can see the root level, you can see everything was fine. After this, might be erupting the tooth to the occlusal level, what we have done, we inserted 1925 SS wire for might be 4 to 6 months for stabilization. Then we finished the case. You can see the results. The patient was very happy. The doctors, the surgeon, the orthodontist specialist, Dr. Ayjuria, were very happy. I was very happy with these results, and I don't know if you are happy, but if you are happy, you can say that you are happy with these results. And you can see the gingival margins. There's no surgical, there's no gingival surgery required. All things were very nice in this case. You can see these models. These are the models, superimposition of the case. And this is the patient, and it seems he is very, very happy. I don't know if he will become orthodontist in the future or not. You look at this profile with profile. Now, the second case, how to utilize the orthodontic, the surgical adjunctive procedures and the orthodontic daily practice. Moving, the second case is about moving the teeth through the cortical bone. You know that we couldn't move the teeth through the cortical bone. It's very difficult. The cortical bone is cortical bone has a high density, and we couldn't move the teeth in the cortical bone. It's very difficult, and it might be cause root resorption, severe root resorption. So we don't do that regularly. In this case, this was a canine transposition of canine to the lateral position. And if you see this case, this is the frontal view and this is the lateral view. And this patient came in the last summer in August. You can see also this CBCT. Frankly, I don't remember that I asked this patient to do cephalometric radiographs or to do panoramic. I just asked him, I said to his father, just go and bring this CBCT to me. I don't need extra radiation for the patient, but I need to see everything. And to be honest, my first feeling was to extract this tooth. But if you look here, there is enough space for canine, and there is nothing about trying. You can try it. You can just warn the family, the parents, the mother that, okay, it might not work, it might not move, but we will try to move this tooth to its position, and we will see. His age was 14 years. He was a male. So if you look also, I don't know this work or not. Yes, that's great. Just look at this. I don't need it to be quickly. I will move it myself. Okay, please look at this. You can see this root here. Okay, you can see those root. This is the lateral, this is the central, and this is the upper canine. Yes, you can see here. You can see the cortical bone. Okay. Yes. So if you look here, you will see this is the cortical bone is in the middle of that tooth. Okay. Also, if you look here, it's also in the middle of the tooth. So it's not easy to move it. And if you look at this area, this is cortical bone. So if we move this tooth in any biomechanics, the biomechanics, the might be the force would be something like here, like this line. But in this line, you will see that the tooth should move into the cortical bone, which is not possible. So I started in 19 of August, if you see, using port chain. This is the first appointment of the miniscrew insertion and starting this. Oh, after almost 3 months, you can see that tooth is in its position. If you see here, yes, there is some tipping, slight tipping here. There is no movement after almost 3 to 4 months, okay, in this superimposition. So I suggested on the patient to do some micro osteoperforation. I made 3 holes using a mini screw, a small mini screw. I inserted this mini screw 1 to 3 times in the bone. And this was on 8th of January. If you look in April, if you look at the tooth, it's a new position. Please compare this with this. There is no manipulation in the photos. You can see, okay? And the results were very, very, very nice for me. Now I started alignment of the tooth and I started ligation this tooth to the main wire, which is night eye wire. Okay, and if you see it's good, I started here also to rotate the tooth using this bottom from the palatal side of the canine. So this is the another case, and this another case I said this is a very good. I don't know, I was lucky to try this technique here. Now this is the last case. Also in the last case, there is some unusual cases, and in this unusual cases, you can try each technique. It's not easy sometimes. So in this patient came to open a space for to implant a tooth here. This is the incisor and this is the canine, and to implant lateral incisor. There was no space, and after 6 months of canine retraction, also there was no space. There was no specific reason. Please mute yourself. Okay. So what I have done also in this case, I start retracting the canine for 4 months, and after 4 months there was nothing. I used the mini screw, infrazygomatic mini screw, and I start retracting the canine. But as I said, there was no improvement. So if you see in this case, there was a curved root, a very long root and curved root. So it was very difficult to open space because this was the curve of the root. So frankly, I translated to this issue or this problem to the parents of the patient. And also I said to them that we can try to do this micro osteoperforation. I did that 2 times, frankly, and after 2 times, you can see this. Now the implant can be done, and the surgeon did this implant I think 2 or 3 days ago, and everyone was satisfied and everyone was happy, and I was happy in this. And thank you for listening. Now I will have some time for questions and answer. If you have some questions, I'd be very happy to answer your questions. So please, if you have any question. Yes, almost 1 hour. You can also write these questions in the chat box. If you need any explanation, I also can explain something in this meeting or this conference. How do you perform MOP? Okay, micro perforation. How can I do this? I do this using simple, very simple technique. Sterilized mini screw. Okay, from this sterilized mini screw, you can do a perforation. Okay, you can measure the space between the tooth. You can decide in which space you can put this. Okay, might be micro anesthesia. You can use some of this anesthetic ampoule inserted under the soft tissue. This make this infiltration, anesthetic infiltration. Then you can do this perforation for 3 or 4 millimeter, yes, 3 or 4 millimeters. The depth of this perforation, it's up to you, but you should calculate the soft tissue thickness. Like the soft tissue thickness, sometimes mostly it's 2 millimeter. So 2 millimeter and 3 millimeters is something like about 5 millimeters. So 5 to 6 millimeter, it's good. You can insert your mini screw for up to 5 to 6 millimeters. And that's all. You can make it, you can make 3 holes, 1 hole, 2 holes, it's up to you. I hope now it's clear. Thank you, everyone. So please, if you have another questions, either related to evidence-based practice, to the surgical adjunctive procedures or other procedures, minimal important difference, smallest worthwhile effect, I can answer these questions. Okay, if you have no questions, just make thumb up and I will end this presentation. So my last word is, don't be a supportive for a technique and don't be against a technique. Just be in the middle and use your mind and use your wisdom, okay, to utilize any new procedure in your orthodontic practice. Don't listen to the author conclusions. Enhance your ability to criticize papers and to understand papers as well. As I told you in the first of this lecture, that canine retraction is not important outcome for the patient. It might be important outcome for the researcher to find something positive and to publish his paper, but it might not be important outcome for the patient. Search for the important outcomes for the patients, and that's all. So thank you everyone for this, and see you again in other meetings. Thank you everyone.